Okay, so now we have, we're going to talk about cardiac issues having to do with the pumping mechanism, heart failure, and other things like that. So, um, heart failure is probably leading diagnosis for patients 65 and over. These are the patients you see elderly in the hospital. Most of them have some form of heart failure. These are the people that are readmitted. These are new cases, deaths. This is a horrible disease that, unless you have a heart transplant, you will not, you cannot cure heart failure. You can just treat the symptoms. So, causes of heart failure. Well, the probably number one thing is advancing age. As you age, your heart just doesn't work as well as it did when you were 22 years old. The other issues are long-term comorbidities such as hypertension, cardiac, coronary artery disease that got worse, rheumatic fever, cardiomyopathy, valve disorders, so valve problems over the years, diabetes, obesity. All of these are going to influence the stage and the how poor or how bad heart failure is. So African Americans have the higher incidence of heart failure. It starts younger and they have a high mortality rate. There is a drug that's out there now called isosorbide dinitrate hydralazine that actually was developed for African Americans. That's the larger group, so that's the one that it was made for. This ethnic group doesn't mean you can't take it if you're not part of that ethnic group, obviously. Asians have an extremely high risk of that ACE inhibitor related cough. So all this stuff is genetic. Can't do anything about the genetic component. Okay, so heart failure. The body wants all the organs to have sufficient oxygenation. Remember, oxygen is carried by the hemoglobin. If you're low in hemoglobin, low in iron, you're not going to carry enough oxygen. Cardiac output is the amount of output of blood the heart um, expends in an average minute. So when I talk about cardiac output, you need to increase your cardiac output. Yes, it's the blood flow, but how they're measuring that is how much is being, um, every time there's a cardiac systole, how much leaves the heart. So if not enough blood flow or slash oxygen leaves the body or gets to the organs of the body, then the body has mechanisms to increase the cardiac output. So some of these all make sense. You already know all of them. You had these in other courses, but whether you remember them, well, that might be another thing. So let's talk about a few of them. So your cardiac output, the formula for that, just remember, is heart rate time stroke volume. So anytime you want to increase your cardiac output, if the heart rate goes up, that'll increase your cardiac output. Now we know this because that is the sympathetic response. That is the easiest response by the body. So this is basically the flight or flight. Um, Heart rate goes up, cardiac output goes up. So that's the easy one. Normal average cardiac output is 4 to 8 liters a minute. That's the average. Stroke volume is the volume of blood pumped with each heartbeat. So if you can increase the stroke volume, if you can increase the heart rate, you will increase cardiac output. If you do either one of those, that will increase the cardiac output. So sympathetic and parasympathetic is your heart rate. How does each one act on the heart? Well, one will lower the heart rate. Parasympathetic goes down. Sympathetic response goes up. So there's three components of your SV. The preload, that's the volume of the blood in the left ventricle at the end of diastole. So if you can increase the preload somehow, you would have a higher stroke volume. The resistance, the afterload, is the pressure that the ventricles pump against. So blood pressure. If you had high blood pressure, your heart has to work harder to get blood out of the heart. So if you could decrease your afterload, you would increase your stroke volume. Then the contractility, also, if you can increase your force of myocardial contraction, that also would increase your stroke volume. So we can play with these three things on increasing your cardiac output. Now, some of these things, you can look at it easily and say, well, if I decrease my blood pressure by blood pressure medications, that would increase your stroke volume. Yes. If I could increase contractility, for example, digoxin, that also would increase stroke volume. Yes. Now, the other thing that we can't do a lot about is the ejection fraction. So if a patient has a heart attack and they destroy some of their heart muscles and decrease their ejection fraction, we just have to work with what we have. We can't fix that one. There's not a pill out there that's going to increase someone's ejection fraction. It can increase the preload, but ejection fraction is basically it's going to be set, and if it's less, it's because of valve problems, because of heart attack, because of cardiomyopathy, things of that nature. So all compensatory mechanisms have one goal. The goal is to keep O2 saturations up for all vital organs. That's the number one goal. So signs of hypoxia would be what? What are signs of hypoxia? Okay, think about that. Look it up. Okay, heart compensation. Sympathetic response. The epinephrine, norepinephrine response will increase the heart rate. That's the sympathetic response. We also have neurohormonal responses. What are the neurohormonal responses that we have? So if cardiac output falls, you're going to have decreased blood flow to the kidneys. Kidneys then will do something to try to increase that cardiac output. If we have decreased blood flow to the brain, we are also going to have a response that's going to increase cardiac output. At least it'll try. Depending what your heart failure issues are or how extensive they are, it may or may not work. So remember renin. Renin changes angiotensin 1 to 2. How does this work? Well, this is constriction. This is a vasoconstriction issue. Aldosterone. Aldosterone from their adrenal glands is going to reabsorb sodium. So the idea originally is if I have more fluid in my body, in my intravascular, the heart will work harder and beat out more fluid and more blood because I have more fluid on board. That's why this one works. That's the genetic piece, the makeup, so we have greater outflow. And it all goes back to I want more oxygen flowing. If the cardiac output falls, we have decreased cerebral perfusion pressure. The pituitary then is going to secrete an antidiuretic hormone that says, let's hold on to more fluid. If you have more fluid, the heart will beat better. The heart will have more oxygen outflow. The heart will help keep oxygen levels up. So technically in a 22-year-old, somebody with no heart problems, all of these things work normally, they work efficiently, and that's what happens, and it does work. So you could have left or right-sided heart failure. Left-sided failure basically reduces your left ventricle, how much it is going to work, the function of the left ventricle. So you have decreased cardiac output from the left ventricle because it all goes through the left ventricle up to the aorta and then disperses systemically. If you have left ventricle failure or heart problems, heart failure in the left ventricle, the blood that goes to the left ventricle now is coming from the lungs to the left aorta to the left ventricle. It'll start backing up into the lungs. So you have stasis of blood in the pulmonary area. That's why pretty much every patient that has heart failure will have crackles in the bases of the lungs. That blood is pooling and backing up because of failure in the left ventricle. Now you can have biventricular failure, both sides, left ventricle and right ventricle. So let's talk about right ventricle. Right ventricle, you have reduced capacity from the right ventricle to the pulmonary circulation. So blood is not getting to the lungs as well as it should from the right ventricle. Now you have blood pooling in the venous circulation. So edema in your limbs. You also have increased central venous pressure. Normal is 2 to 8, 2 to 9. That pressure goes up because now you have more fluid in the venous system. So increased central venous pressure. Now, right failure is usually brought on by a heart attack, a bad valve. That's what happens here. Left ventricle can just happen because of the aging. This is the aging thing. Also because of a heart attack, valve problem. Usually, a very elderly patient who's had heart failure for a long time, if you don't have both left and right failure, say you start off with left failure, you eventually will have right failure just because of everything backing up and how everything works together. So tests, how can we find out if someone has heart failure? Well, echocardiogram you can do and see how the heart's functioning. Sometimes with heart failure, or lots of times with heart failure, especially left ventricle failure, your heart will become enlarged, so that left ventricle gets larger. You can do a cardiac catheterization where you can actually measure the EF, you can actually look at the valves, you can look and see what's going on in real time. Some patients have heart failure, and if it's post-MI, you can see that on an EKG. There is a peptide out there called BNP, brain natriuretic peptide, that is put out by the ventricles. This basically peptide, because of the stretching of the cardiac muscle and cells, this releases this peptide. This peptide originally is released because there's too much blood now. Now we have too much. So this is basically a diuretic. So when this number goes up, you know that the heart muscle is stretching, left ventricles, and basically it's saying I've got too much fluid on board. So this is an indication how high the BNP is to how horrible or extreme the heart failure, left-sided or right-sided failure can be. There is the New York classification. Class 1 of heart failure is patient doesn't have any undue fatigue or dyspnea. The patient probably doesn't even know he's starting heart failure. Class 2 is slight limitation, meaning activity now is starting to get fatigue, dyspnea. That's starting to be noticed. Class 3 is marked limitation. Class 4 is you can't perform any level of physical activity without discomfort. So we've got class 4. So anywhere from 2 to 4, you go from the slight to extreme. You can't do anything. So some doctors' definition of class 3 may be a doctor's class 4, class 2 to 3. So these are it just gives you an idea. So remember, class 4 is you can't perform anything. Class 1 is you don't know any change, and anything, the other two are in between.